I remember talking to Paul Winner, who at a headache conference in New York many years ago, and he's a headache expert in Palm Springs, and he runs a headache centre there just in children, and asking him about the prevalence between boys and girls up to the puberty age. And his opinion is that there are more boys that suffer up to puberty with migraine, and after puberty it turns on its head and it becomes way more common in young women than boys, and that a lot of boys actually grow out of migraine as they go through puberty, rather than many young girls actually becoming debilitated with the migraine through the puberty years and the onset of the hormonal changes. And we'll touch on that as we go through the presentation. I think that the main aim of what I think about when I talk to any migraine sufferer is, number one, how to treat the pain, and number two, how to treat the disability that's associated with all the symptoms, and how to improve quality of life for those that would attend our service who would be very debilitated with migraine. So migraine is primarily a disorder of men and women that, for us, when we see migraine at its worst, it would certainly be at sort of the midlife. So certainly in the age 30 years to 40, that would be the age group mainly that would attend Beaumont. But when I take a history and look at, migraine, and go right back, when we take a history of when we present any case history in Beaumont, we go right back to childhood. So we're going right back to when did the migraine first start, and many people will just go back to when it worsened and say, well, it started 3 years ago, and they could be in their 40s, and I say, no, hang on, let's go right back, I'm talking about childhood. Did you have migraine as a child? And they would say, well, I remember my mum used to say I used to, at the birthday party when I was 8, get migraine, and I had to go into a dark room and lie down, and the symptoms were there, and it might have been very infrequent, very non-disabling, but it was there. It was maybe at the child's birthday party or the school tour, or maybe them playing for Dublin in the match, or whatever it might be, times of excitement, times of stress, whether it be positive or negative stress, that maybe the events were happening, and maybe, and then they presented and worsened throughout the life. And many grow out of migraine, and unfortunately for many, I'm talking menopausal years, so the parents that are here will say, God almighty, you're talking 30 years of migraine. And yes, the majority of those that suffer with migraine, you're talking about teenage years right through to menopause, with varying different levels of the change of pattern. Some people get 1 or 2 attacks a year, some people get 1 or 2 attacks a week. So there are various different levels of the pattern of migraine and how it affects somebody. In my experience of all the years I've worked with migraineurs, I would think about 70% of migraine is genetic, and it's very female linked. It's very much the mum or the grandmother, and it follows down through the legs, so you can sue your parents for your migraine. About 10% of children suffer with migraine, and that's from age 5 to 15%, so the percentage is quite high. Paul Winner told me about 7%, but I think that through education, this was about 10 years ago when I met him, he talked about 7% of children suffering with migraine. Now the statistic in around 10%, which is quite high. That's quite a high statistic for migraine for children. There is no diagnostic test for migraine. When they do the tests, and when the neurologists do the tests and the investigation, they're outruling a secondary cause, because number one concern for any parent who has a child with headache and constant recurring headache is this a brain tumour? Is this subarachnoid hemorrhage? Is this something more sinister? What is this? Why is this occurring? Is there something else going on in the brain? So very often they will do the scans and the investigations, not only to reassure themselves that there's nothing else, but also for the patient and for the parents. I find when I talk to parents that the younger children find it more difficult to describe the symptoms. So, when I talk about the sensitivity to light or sound or smell, which a lot of children do get with their migraine, the younger children may not be able to describe that feature, because they're actually, maybe it's more their tummy, and they just want to go away and lie down and sleep it off for maybe 2 hours and it's gone. So that and it's only when you probe with the questions that you realise that they do need to actually get away from noise and get away from lights and go into their bed and lie down, but they might not actually be able to describe those symptoms. So it is important that when they're well, that you kind of focus back, because a lot of the parents actually suffer with migraine themselves, so they be in tune with the characteristics of the diagnosis. So it's important to try and maybe jot it down so that when the doctor is making a diagnosis, that this is how they do it. I love to talk to your group because the disability is increasing with the severity of the attack growing. The majority of the attacks in children are from 1 to 48 hours. For adults, we talk about 4 to 72 hours. And Audrey actually touched on this earlier in Brian's presentation. And that's the kind of the difference between adults and children. The attacks tend to be shorter duration. There seems to be fewer attacks as well, and fewer attacks in the mornings. They tend to be more evening attacks for a lot of adolescents. The attack tends to be less severe, but yet there's a lot of abdominal discomfort and vomiting. The attacks are easier to treat, so easier to stop from progressing. So if you're treating the attack with Migraine or Nurofen came up this morning, or whatever it is that you treat the attack with, early intervention is very important with these drugs, and that they're easier to treat, so the acute treatment should work much quicker for children than in adults. And a lot of children find sleep is the key, that if they can get to sleep, that once they wake up the attack has recovered. And I can see so many of you nodding and saying yes, that's your experience, and that would be my experience from my intervention with adolescents as well. So just to let you know, there are two common types of migraine. There's migraine with aura and migraine without aura. The majority of migraine patients do not get the aura. So those of you that get the aura are in the rarer group. They're called focal neurological signs for us that work in clinical practice all the time. And they're also a warning that your migraine is about to come. When I take a history, I nearly always draw the aura. Do you get floaters that come down in front of the eyes? Anybody get that? Okay, a curtain maybe crossing over in front of the eye, that's very common too. And the tadpoles that kind of swim around in the eye and out in the periphery of the vision, nearly always out in the side. A lot of patients get that. And the most common is called scotoma, so their shapes getting bigger and smaller. So like little black spots, and they grow, or little shimmery objects, that's very, very common, that grow in size. The other common feature in migraine aura is the spreading of a numbness or pins and needles, usually starting in the two fingers in the extremities and spreading up into the hand and into the arm. Also, it can spread into the face, a little bit of numbness here in the face. This is the trigeminal nerve here in the face, into the lips, into the tongue. And the other aura symptom is mixing up words. So the speech then is the other symptom. Some people get slurred speech. I find that's mainly adults, but some people find that they're mixing up words, or find word articulation more difficult. So if you wanted to say, can you lift that pen, you find it difficult to say the word pen, or you might mix up names of your children, for instance, mixing up names of a dog and a cat, that kind of thing. So that's also common, but probably more common in adult migraine. I mean, drawing of the aura is very important. So if you are going to go to your GP or to your neurologist, for instance, and always to remember that these guys are so busy, and I know that that's the services and the resources are a nightmare, and it's difficult even to come to the headache clinic in Beaumont because it's so busy. Okay, another question. Do you get a headache during a migraine attack? Yes or no? Okay, so that just shows you guys. So many of you get the actual headache with your migraine, 97%. It also probably shows the adolescent group. Just before I go on to abdominal migraine, just so you know the common features of migraine, very often in children, migraine tends to be bilateral rather than unilateral, so they can get headache on both sides. Now this, unilateral headache is part of the diagnostic criteria for migraine, but a lot of adults also get the bilateral headache, but for children it can be bilateral or one-sided, left or right-sided. Throbbing or pulsating in nature, that's also one of the feature characteristics of diagnosing migraine, with the sensitivity to light or sound with associated nausea, and you could see that getting, such a large percentage got nausea and vomiting with their attack. and also exacerbated by routine activity or moving around. So that's why so many need to lie down in a room when they get their migraine. And this is the other very common type of migraine, which is abdominal migraine, really. And I think that this is probably from a younger age. But as you might remember back, if your migraine was there when you were younger than this, was it more abdominal features at the time? It's kind of periumbilical, so it's around the umbilical cord, really, where they get a lot of nausea and vomiting, pale and sensitive to light and noise, like I said. Reoccurs like migraine, so it's quite cyclical, it reoccurs. And the patient is usually very well in between attacks. And of course, like what Brian Lynch said, you always have to outrule bowel infection or something else. So very often, you'll have gone around and seen a paediatric specialist and then gastro people and then end up going to see a neurologist sort of down the line. That's very often what happens. Okay, so do you keep track of your migraines with a migraine diary? Oh, that's really interesting, because probably the most effective tool that you can do to help manage your migraine for both yourself and for your doctor is to keep a migraine diary. And it's something that we use all the time in Beaumont. And some patients will say to me, oh, the doctor didn't have any interest in the diary when I kept it and I brought it in, but use it for yourself as well. And if they don't, well, you can't really do much about that. But certainly I look at the diaries, I look at everybody's diary if they keep it. I usually ask them, why didn't you keep a diary when they come to me? But it's a really effective tool, management tool, is to keep the little diary. And children are inclined to keep really good diaries. Any of the adolescents that I've had are very, very, very well illustrated diaries when they bring them to me. And very often we can identify lifestyle change and maybe triggers that maybe somebody never thought about could trigger the migraine. That's what we would utilise it most for. And also then to optimise drug treatment, so looking at both acute and preventative treatment options, that the diary would be really helpful. Because normally when a migraine patient attends us, it could be 3 to 4 months before you come back. I mean, I can hardly remember what happened last week, let alone 3-4 months ago. So it's really important to keep a diary, and it's really, really useful. So if I could encourage you all to keep diaries, that would be something that I would advise.